Welcome back to the Deep Dive. Today, we're tackling something pretty substantial. We have this huge set of source material, really detailed notes covering the nursing management of adult clients with cardiovascular disease.
Yeah, it's quite a stack.
It is. And this isn't just a quick flyby. We're aiming for a really comprehensive, thorough walkthrough, taking these notes you've gathered and structuring them into something memorable, something practical.
Right, a proper deep dive into the whole CV cascade, as you said. The material here, it really covers the spectrum. I mean, from basic heart mechanics, how blood flows, all the way to complex drug interventions and even post-surgery care.
Exactly. So the goal here is to make sure you, the listener, don't just memorize facts, but really grasp the connections, the why behind certain protocols, why we act fast in specific situations.
That's the key, because successful CV management, it really hinges on understanding that core physiology first. Knowing how things should work before you can spot when they're going wrong, especially those acute changes.
Makes sense. We want to provide that structure, highlight the really high-impact stuff like, what's the difference between stable and unstable angina? What does that little blip on the EKG, the ST segment, actually mean? When does the clock really start ticking during a heart attack? We want to unpack all the detail these notes offer.
Okay, so let's start at the beginning, the fundamentals. Because like I said, everything else builds on this. We need to understand the heart's job mechanically, electrically, before diving into the problems.
You're right, let's do it. Okay, foundation one, the engine's performance. Cardiac output, or CO, sounds like a simple formula, but managing CO is pretty much the heart of cardiovascular care, isn't it?
It really is. Cardiac output fundamentally is just how much blood the heart pumps out into the body each minute. And that basic formula, CO equals stroke volume times heart rate, well, it tells us exactly what levers we can pull.
Right. If the output's low, you either speed up the heart rate or you increase the amount pumped with each beat the stroke volume.
Exactly. And it's that stroke volume piece where things get a bit more mechanical, talking about fluid dynamics, pressure, specifically preload and afterload.
Yes, preload and afterload. These two definitely cause confusion. Can you break down the practical difference for us? Make it really clear based on these notes?
Sure. Let's try an analogy. Think of the heart muscle, maybe the left ventricle, like a rubber band. Preload is how much you stretch that rubber band right before you snap it.
Okay.
So technically, it's the volume of blood filling the ventricle at the end of its relaxation phase, diastole. It's the stretch caused by that volume. Starling's law tells us up to a point, more stretch means a stronger snap, a stronger contraction. So preload is mostly about how much blood is returning to the heart. Venous return dictates preload.
So if someone's dehydrated, maybe bleeding, their preload would be low. Not enough stretch.
Precisely. The heart doesn't fill well. On the flip side, if someone's in heart failure, overloaded with fluid, their preload is way too high. The muscle's overstretched.
And that's when we might use diuretics to reduce that volume, reduce the stretch.
Exactly. Now, afterload is totally different. If preload was the stretch before the snap, afterload is the resistance that rubber band encounters as it snaps forward. It's the force the heart has to overcome to push the blood out into the circulation.
So things like high blood pressure or narrowed, stiff arteries, they increase the afterload, make it harder to pump.
Immensely harder. High afterload means the heart has to work incredibly hard just to force open the aortic valve and eject blood. This drives up the heart's workload and, crucially, its oxygen needs.
Okay.
Clinically, preload is tricky to measure directly without invasive lines, but afterload, we often think about it in terms of blood pressure or systemic vascular resistance, SVR. When we give medications like vasodilators, we're often trying to lower that resistance, lower the afterload, make it easier for the heart to pump.
Got it. So understanding volume coming in preload and resistance going out afterload is fundamental.
Absolutely central. It impacts almost everything else we'll discuss. And of course, as the notes remind us, all this happens within the heart structure, the chambers, valves, major vessels. That anatomy is the stage for all this action. Tag 1.2, decoding the electrocardiogram, EKG, ECG.
Okay, so that's the plumbing, the mechanics. Now for the wiring, the electrocardiogram, the EKG or ECG, Probably the most crucial immediate diagnostic tool we have, right?
Without a doubt. It's giving us a real-time picture of the heart's electrical activity, the conduction system. But yeah, to the untrained eye, it's just lines on paper or a screen.
We need to translate those lines, those waves, into what's actually happening electrically in the heart cells.
Right. It's like learning the language of the heart's electrical impulse. We're tracking depolarization, the electrical signal for contraction, and repolarization, the electrical reset. Every wave, every interval tells a story about where the impulse is and if it's moving correctly and on time.
So let's walk through the typical sequence from the notes. It starts with that first little bump, the P wave.
The P wave represents atrial depolarization. That's the spark starting in the SA node, the heart's natural pacemaker, and spreading across the top chambers, the atria, telling them to contract.
Okay, then there's usually a little flat line, a pause.
Right, that pause is important, happens at the AV node, then comes the big one, the QRS complex.
That's the main event on the strip, usually.
It is, because it represents ventricular depolarization. It's the massive electrical surge as the main pumping chambers, the ventricles, get the signal to contract. They're so muscular, the electrical activity is much larger.
And after the QRS, there's the T wave. Kind of broader, rounder, usually.
The T wave is ventricular repolarization. That's the electrical reset phase for the ventricles. They need to get back to their resting state electrically so they can relax, refill with blood, and be ready for the next beat.
Now, the notes emphasize that the spaces between these waves, the intervals and segments, are just as important, if not more so sometimes.
Absolutely. They tell us about the timing and health of the conduction. The PR interval, for instance. It measures the time from the start of that P wave, the atrial signal, to the start of the QRS, the ventricular signal.
So it shows the delay at the AV node.
Exactly. If that PR interval is too long, it suggests a delay, what we call heart block. But maybe the most critical part, especially in emergencies, is the ST segment.
Right, the section right after the QRS and before the T wave. This is a big one in the notes.
It's a huge indicator. The ST segment reflects that early phase of ventricular repolarization. Its position relative to the baseline, whether it's elevated, pushed up, or depressed, pushed down, is often the very first sign of serious trouble, like ischemia or an actual heart attack.
Okay, super critical. And the last interval mentioned here is the QT interval.
The QT interval measures the total time for the ventricles to complete their whole electrical cycle depolarization and full repolarization. If that QT interval is abnormally long, it means the ventricles are taking too long to reset electrically.
And that's dangerous.
Very. It puts the patient at high risk for life-threatening arrhythmias like torsades de pointes. So, P wave, QRS, T wave, PR interval, ST segment, QT interval. Each piece gives us vital information. Hashtag tag 1.3 basic rhythms and acute abnormalities.
Okay, so if everything's working electrically as it should, we get what's called normal sinus rhythm, heart rates between 60 and 100 beats per minute, all the waves look right.
That's the baseline we hope for.
But when the rate strays outside that, even if the rhythm is regular, we get the basic variations. Sinus bradycardia if it's too slow, under 60,
Right.
and sinus tachycardia if it's too fast, over 100.
Direct. Those are rate issues primarily.
But the notes really focus on the acute abnormalities, the rhythms that signal immediate danger. Let's start with atrial fibrillation, AFib. It comes up again and again because of the risk.
AFib is, well, it's electrical chaos in the atria. Instead of that nice single P wave showing organized atrial contraction, you just get this wavy, irregular baseline, no discernible P waves. The atria are just quivering, fibrillating.
This leads to an irregular pulse.
Yes, the ventricles get bombarded with irregular signals from the chaotic atria, so the ventricular rhythm, the pulse you feel, is typically irregularly irregular. It can be fast, it can be slow, but it's unpredictable.
But the notes stress, the biggest danger isn't necessarily the rate itself, though that can be a problem.
Right. A very fast rate over time can definitely strain the heart and lead to heart failure. But the most immediate life-threatening risk from AFib is clot formation.
Because the blood isn't being pumped out effectively from those quivering atria, it just pools.
Exactly. Stasis. That stagnant blood in the atria, especially in the little appendage off the left atrium, is highly prone to clotting. If a piece of that clot breaks off,
It travels. Stroke risk.
huge stroke risk. That's the major concern. So management, as the notes detail, has two immediate priorities. First, anticoagulation blood thinners to prevent clots, often lifelong. Second, controlling the ventricular rate, usually with beta blockers or calcium channel blockers, to slow the heart down and allow the ventricles to feel better.
Makes sense. There's another related atrial rhythm mentioned, atrial flutter. How's that different?
Atrial flutter is also an abnormal rapid rhythm starting in the atria, but it's more organized than AFib. It's caused by a sort of electrical short circuit looping in the atria.
It has a classic look on the EKG.
It does. The hallmark is the saw-toothed wave pattern instead of P waves. It looks like the teeth of a saw blade. Management goals are similar: rate control, anticoagulation, but sometimes procedures like cardioversion or ablation can actually cure atrial flutter by interrupting that circuit.
Okay. Now let's go back to that crucial ST segment we talked about. The notes highlight the difference between elevation and depression as indicating different levels of damage.
This is absolutely critical in an acute setting. ST elevation, meaning the segment is lifted, usually 1 millimeter or more above the baseline, and at least 2 leads looking at the same area of the heart. This is the classic sign of an acute myocardial infarction that's affecting the full thickness of the heart wall, a STEMI.
And that means,
It means tissue is dying right now. The artery is likely completely blocked. It's a code red emergency requiring immediate reperfusion therapy, opening that artery back up.
okay, so elevation equals injury, infarction. What about ST depression?
ST depression, where the segment is pushed below the baseline, typically signals ischemia.
Ischemia, meaning lack of oxygen, but not necessarily cell death yet.
Exactly. The heart muscle isn't getting enough oxygenated blood, usually due to a severe blockage, but the cells haven't died yet. It's still an emergency, often indicating unstable angina or an NSTEMI, non-ST elevation MI, but the implication is slightly less immediate than full-blown ST elevation, though both need urgent attention.
Understood. And one last practical point from the EKG section in the notes, a simple nursing consideration during the test itself.
Yeah, it sounds basic, but it's vital for getting a clean tracing. Any patient movement, even shivering or tremors, can create electrical noise artifact on the EKG.
Which could look like a dangerous rhythm.
It absolutely can. It might mimic something serious like VFib or VTach. So, the simple instruction is key. Ask the patient to lie as still as possible, relax their muscles, breathe normally, and try not to talk just for those 10 seconds or so while the machine is recording. Clean data is crucial.
Okay, we've got the basics, the pump, and the wiring. Now let's dive into the underlying disease process that causes most of the problems. Coronary atherosclerosis, or CAD. The notes frame this as the origin story of heart disease.
That's a good way to put it, because CAD is this slow, progressive buildup of plaque fatty deposits called atheromas inside the coronary arteries, the vessels feeding the heart muscle itself. And it often starts silently, years, even decades before symptoms appear.
And it all begins, according to these notes, with damage to the artery's inner lining, the endothelium.
That's the initiating event, injury to that delicate endothelial layer. And what causes that injury? Chronic insults. Things like smoking, the constant pressure of hypertension, high levels of circulating lipids, especially LDL cholesterol, the bad kind, and also high blood sugar from diabetes. These factors damage that smooth inner lining.
And once it's damaged, it becomes sticky, inflamed.
Exactly. The injury triggers an inflammatory response. It's the body trying to repair itself. But in this environment of chronic insult, the repair process goes haywire.
How so?
Well, inflammatory cells rush in. Immune cells called macrophages start gobbling up the excess lipids, particularly oxidized LDL, and they transform into these bubbly-looking cells called foam cells.
Foam cells. Okay.
Yeah, they're basically lipid-filled macrophages. Then smooth muscle cells from the artery wall migrate into the area, collagen gets deposited, calcium starts to accumulate, and slowly this whole mess builds up into a plaque with a fibrous cap covering a soft, fatty core.
And this plaque physically narrows the artery.
Right, it obstructs blood flow. When it gets significant enough, maybe 70% blockage or more, that's often when people start feeling symptoms like angina, especially during exertion when the heart needs more oxygen.
But the notes stress that the real danger, the thing that causes a heart attack, isn't always just the narrowing itself. It's when the plaque ruptures.
This is the critical event. A stable plaque might cause predictable angina, but if that fibrous cap covering the plaque weakens and breaks open, maybe due to high blood pressure, inflammation, or just mechanical stress, it exposes the highly thrombogenic fatty core material inside the plaque directly to the flowing blood.
Thrombogenic meaning it triggers clot formation.
Instantly, platelets rush to the site, aggregate, and activate the clotting cascade. A thrombus, a blood clot, forms right there on top of the ruptured plaque, and that clot can rapidly grow large enough to completely block the artery within minutes.
And that's what leads to acute coronary syndrome, or an MI.
Precisely. Plaque rupture and subsequent thrombosis. That's the mechanism behind most heart attacks. Hashtag tag 2.2 clinical manifestations and atypical symptoms.
So, given this slow buildup, many people with CAD have no idea they have it until it's quite advanced. When symptoms do finally show up, the classic one we learn about is angina pectoris, chest pain.
Right. The classic description is often that deep substernal pressure or tightness, maybe a squeezing, choking feeling, or like an elephant is sitting on the chest, and it might radiate.
The jaw, the neck, down the left arm, maybe the back.
Exactly. Sometimes it can even feel like indigestion or epigastric distress. That's the textbook picture.
But the notes make a huge point about not relying solely on that classic picture. Recognizing atypical symptoms is vital.
Absolutely life-saving. Because large groups of patients present very differently, and if you're only looking for classic chest pain, you'll miss them.
Who are we talking about primarily? Which groups tend to have atypical signs?
The big ones mentioned are the elderly, patients who have diabetes, especially long-standing diabetes, and those who already have heart failure. In these individuals, the main symptom, or sometimes the only symptom, of an acute cardiac event might be sudden, severe shortness of breath, SOB.
Not chest pain, but just can't catch their breath.
Exactly. Or maybe profound, unexplained fatigue, dizziness, or confusion, especially in the elderly. If they come in saying, I just suddenly feel terribly weak and out of breath, you have to think cardiac, even without the chest pain.
And the notes also specifically highlight differences in how female patients often present.
Yes, this is crucial. Women are more likely than men to experience atypical symptoms during a cardiac event. They might report things like indigestion, nausea, vomiting, extreme fatigue or weakness, palpitations, or even just numbness. The discomfort might be felt more in the back, between the shoulder blades, or in the neck or jaw, rather than the front of the chest.
And these symptoms are easily dismissed, aren't they?
Very easily. Chalked up to anxiety, GERD, maybe muscle strain, which leads to dangerous delays in diagnosis and treatment. So the takeaway here is crystal clear. In any patient at risk for CAD, especially these specific populations, any new unexplained symptom, particularly sudden SOB, severe fatigue, or unusual GI distress, needs a cardiac workup until proven otherwise. Don't wait for classic chest pain. Hashtag 2.3 risk factors and metabolic syndrome.
Okay, so we know atherosclerosis starts with that endothelial injury. This naturally leads us to risk factors, what causes that initial damage. The notes divide them into non-modifiable and modifiable. Let's quickly cover the ones we can't change.
Right. The non-modifiable risks are the hand you're dealt, essentially. Genetics definitely plays a role. If you have a strong family history of early heart disease, your risk is higher.
Age is another big one.
Yeah, risk increases with age. Generally, men over 45 and women over 55 are considered at higher risk. The notes also point out men tend to develop CAD earlier than women, though that gap narrows after menopause.
Ethnicity plays a role, too.
Yes, there's a higher incidence noted in African Americans. And for women, specific factors like experiencing premature menopause before age 40 or having had pregnancy complications like preeclampsia or gestational diabetes can signal increased future CV risk.
Okay, those are the fixed factors. Now, the crucial ones, the modifiable risks, the things we can potentially control.
These are the major targets for prevention. The big ones are smoking, number one enemy, hyperlipidemia, specifically high LDL cholesterol, high total cholesterol, low HDL, good cholesterol, and high triglycerides, hypertension, high blood pressure, diabetes mellitus, both type 1 and type 2, and then lifestyle factors like poor diet, high in saturated fats, processed foods, and lack of physical activity leading to obesity.
And the notes mention that when several of these risks cluster together in one person, it's particularly dangerous. That's metabolic syndrome.
Exactly. Metabolic syndrome isn't a disease itself, but a cluster of conditions that dramatically increases the risk for heart disease, stroke, and diabetes. It signals underlying insulin resistance and chronic inflammation.
We need to know the specific criteria that define it, right? The notes list 5 key metrics.
Yes, a diagnosis of metabolic syndrome requires having at least 3 out of these 5 specific risk factors. 1, a large waistline. This indicates central or abdominal obesity. The cutoff is greater than 35.4 inches for men and greater than 31.4 inches for women. 2, elevated triglycerides, high levels of this type of fat in the blood. 3, reduced HDL cholesterol, low levels of the good cholesterol, specifically less than 40 mg/dL for men or less than 50 mg/dL for women. 4, hypertension, high blood pressure, or being on medication for it. 5. Elevated fasting blood glucose, high blood sugar, indicating prediabetes or diabetes, or being on medication for high blood sugar.
So if someone meets 3 or more of those criteria,
They're considered to have metabolic syndrome. It's a huge red flag demanding really aggressive, multifaceted intervention to address all those underlying risks simultaneously.
so prevention is key. It starts with lifestyle changes, and diet is a massive component, particularly for managing cholesterol, that hyperlipidemia, HLD. The notes get quite specific here, moving beyond just eat healthy.
Right. General advice is good, but specific targets help. Diets like the Mediterranean diet or the AHA, American Heart Association diet, are often recommended lots of fruits, vegetables, whole grains, lean protein, especially fish rich in omega-3s. But the macronutrient breakdown is important too.
What are the targets mentioned?
The goal is usually to keep total fat intake between 25% and 35% of daily calories, but critically, saturated fat needs to be less than 7%. That's quite low. Carbohydrates should make up about 50–60% of calories, preferably complex carbs, and protein around 15%.
Fiber is important too.
Very. Aiming for 20 to 30 grams of fiber per day helps lower cholesterol, and dietary cholesterol itself should be limited to less than 200 milligrams per day. These are pretty strict targets for someone with high lipids.
Okay, shifting to exercise. Again, specific recommendations here.
Yeah, the guidelines are clear. Adults need at least 150 minutes of moderate intensity aerobic activity per week. Think brisk walking, cycling, swimming. Or if you do vigorous intensity activity like running, 75 minutes a week is enough.
And it's not just cardio, right?
No, the notes explicitly mention adding muscle strengthening exercises, lifting weights, using resistance bands at least 2 days per week. This helps with overall metabolism, insulin sensitivity, and maintaining lean body mass.
But there's a crucial safety warning attached to exercise for people with known or suspected CAD.
Absolutely critical. Patients need to be taught the warning signs that mean stop exercising immediately. These include experiencing chest pain or pressure, angina, unusual or sudden shortness of breath, feeling dizzy or lightheaded, extreme fatigue that's out of proportion, or nausea.
Pushing through those could be dangerous.
Could trigger an acute event like an MI. So stop, rest, and report those symptoms to their doctor. Exercise is vital, but it needs to be safe.
Next up, tobacco. Smoking cessation is just non-negotiable, isn't it? The notes really break down why it's so bad for the heart.
It's a multi-pronged attack. First, the nicotine itself triggers the release of catecholamines, adrenaline, and noradrenaline.
Fight or flight hormones.
Exactly. And what do? They increase heart rate, they increase blood pressure, and they constrict peripheral arteries. All 3 of those actions dramatically increase the heart's workload and its need for oxygen.
But it doesn't stop there, does it?
Not at all. Smoking chemically damages the blood vessels. It promotes the oxidation of LDL cholesterol, making it much more likely to stick to artery walls and form plaque. It also makes platelets stickier, increasing the risk of blood clots forming if a plaque does rupture.
And then there's a carbon monoxide effect.
Right. Carbon monoxide from smoke inhalation actually binds to hemoglobin in red blood cells more readily than oxygen does. So it directly reduces the amount of oxygen the blood can carry to the heart muscle, a muscle that already has increased oxygen demands because of the nicotine effects. It's a terrible combination.
Yeah.
More demand, less supply, and easier clotting.
It's bad news all around. Okay, finally, controlling the other big modifiable factors, hypertension and diabetes. The BP goal mentioned is tight, less than 30–80 millimeter Hg.
Yes, aggressive BP control is key.
And for diabetes, how does high blood sugar specifically accelerate heart disease? We touched on endothelial damage, but what else?
Beyond directly damaging the endothelium, chronically high blood sugar contributes to dyslipidemia. It messes up your cholesterol and triglyceride levels. It also increases platelet aggregation, making clots more likely, as we discussed. And it promotes inflammation throughout the vascular system. So tight glucose control is essentially cardiovascular protection for diabetic patients. Hashtag 2.5 diagnostics and lipid-lowering medications.
So how do we track these risk factors, especially lipids? The main tool is the fasting lipid panel, or FLP. The notes suggest getting this checked. How often?
The recommendation is generally at least once every 5 years for all adults aged 20 and older. But if someone has risk factors or already has CAD, they'll need it checked much more frequently, maybe annually or even more often, to monitor treatment effectiveness.
And what are the ideal target values we're aiming for, according to these notes?
The targets are pretty clear. LDL cholesterol, the bad kind, ideally less than 100 milli-GDL. But for very high-risk individuals, say someone who's already had a heart attack, The goal is often much lower, less than 70 milli-GDL. Total cholesterol should be under 200 milli-GDL. HDL cholesterol, the good kind. We want this higher. Greater than 40 milli-GDL for men and greater than 50 milli-GDL for women. Triglycerides should be less than 150 milli-GDL.
Okay, those are the goals. If lifestyle changes aren't enough to hit those targets, then we move to medications. The most common are the statins.
Statins are usually first-line therapy. Drugs like atorvastatin, simvastatin, they work primarily by blocking an enzyme in the liver that's needed to produce cholesterol, so they directly lower LDL production. They're very effective.
But they have important side effects and monitoring requirements.
Yes, because they work in the liver, they can potentially cause liver inflammation or damage. So it's standard practice to monitor liver function tests, liver enzymes like ALT and AST periodically, especially when starting therapy or changing the dose.
And there are situations where statins absolutely should not be used. Contraindications.
Definitely. They are contraindicated in patients who have active or chronic liver disease, like viral hepatitis or alcoholic hepatitis. They also shouldn't be used during pregnancy because they can harm the fetus, and they're contraindicated during breastfeeding.
Any other key side effect to educate patients about?
Muscle aches and pains, myalgia, are relatively common. Patients should report any unusual or severe muscle pain, tenderness, or weakness, because in rare cases, statins can cause a serious condition called rhabdomyolysis, where muscle tissue breaks down.
Okay. The notes list other classes of lipid-lowering drugs, too, besides statins.
Right. There are several other options, often used in combination with statins or if statins aren't tolerated. These include fibric acid derivatives, or fibrates. These are particularly good at lowering triglycerides and modestly raising HDL. Bile acid sequestrants, or resins. These work in the intestines to bind bile acids, forcing the liver to use up more cholesterol to make new bile acids. Cholesterol absorption inhibitors, like ezetimibe, which reduces cholesterol absorption from the diet in the small intestine. PCSK9 inhibitors. These are newer, injectable biologic drugs that are very powerful at lowering LDL, often used for high-risk patients who don't reach goals with statins alone.
And the common thread for monitoring, regardless of the class.
The notes emphasize that because many of these drugs impact liver function or have other metabolic effects, monitoring especially liver enzymes remains important across the board. Vigilance is key.
Okay, we've laid the groundwork with atherosclerosis, the chronic buildup. Now let's talk about angina pectoris, the symptom that arises when that buildup starts causing problems. It's basically a warning sign from the heart.
Yeah, exactly. Angina is chest pain, or sometimes equivalent discomfort, caused by temporary myocardial ischemia.
Ischemia meaning not enough oxygen.
Right. The heart muscle isn't getting enough oxygenated blood to meet its current needs. There's an imbalance between oxygen supply, what the narrowed arteries can deliver, and oxygen demand, what the heart needs, especially during activity or stress. That imbalance causes the pain.
The notes stress that differentiating between the types of angina is absolutely critical for knowing how to react. Let's break down stable versus unstable angina.
This is probably one of the most important distinctions in cardiology. Stable angina is predictable.
Predictable how?
It follows a consistent pattern. The patient knows what triggers it, maybe walking up 2 flights of stairs or being out in the cold. The pain feels the same each time, lasts about the same duration, usually short, 5-15 minutes, and crucially, it's reliably relieved by rest or by taking a dose of nitroglycerin.
So it's familiar, manageable, though it still needs investigation.
Right. It signals significant underlying CAD, but it's not usually an immediate emergency. Now, unstable angina is completely different. It's an emergency.
Why? What defines unstable angina?
Unstable angina represents a change from the patient's usual pattern. It might mean the chest pain is happening more frequently, it's becoming more severe, it's lasting longer, or, and this is a major red flag, it starts happening with less exertion or even at rest.
And it's not relieved by the usual measures.
Correct. The key feature is that the pain is not relieved by rest or by taking nitroglycerin, or it takes much more NTG than usual. This change in pattern strongly suggests that the underlying plaque has become unstable, maybe ruptured, and a clot might be forming. It's considered an acute coronary syndrome, ACS, and requires immediate medical attention. Call 911.
Okay, that distinction is vital. When someone is having angina, besides that classic retrosternal pressure, what other associated symptoms might we see, according to the notes?
Because it's a stressful event for the body, you often see signs of sympathetic nervous system activation. Things like pallor, the person looks pale, diaphoresis, profuse sweating, they might feel nauseous, sometimes even vomit. Dizziness or lightheadedness can occur, and often there's a significant feeling of anxiety or apprehension.
And again, the notes remind us about diabetic patients potentially having blunted pain perception.
Yes. The caveat for patients with diabetes, especially those with autonomic neuropathy, nerve damage from diabetes, is crucial. They might not feel the typical chest pain at all. Their anginal equivalent might just be sudden shortness of breath, profound fatigue, nausea, or sweating. Always maintain a high index of suspicion in diabetic patients presenting with these less specific symptoms.
So when someone has symptoms suggestive of angina, or we suspect underlying CAD, besides getting their history in a baseline 12-lead EKG, one of the main diagnostic tools is the cardiac stress test. What's the goal here?
The stress test is designed to deliberately, but safely, increase the heart's workload and oxygen demand under controlled conditions to see if the coronary arteries can deliver enough blood flow. We're essentially trying to provoke ischemia, if it's inducible.
How do we increase the workload?
Usually in one of two ways. The most common is an exercise stress test, where the patient walks on a treadmill or pedals a stationary bike with the intensity gradually increasing. Or, if a patient can't exercise adequately due to arthritis, lung disease, or other issues, we can do a pharmacologic stress test.
Using drugs to mimic exercise.
Exactly. We use medications like dobutamine, which increases heart rate and contractility, or vasodilators like adenosine or regadenoson, which dilate healthy arteries, potentially stealing blood flow from areas served by blocked arteries, to stress the heart chemically while monitoring the EKG and symptoms.
And we're pushing the heart towards its maximum predicted rate.
We aim to get them to at least 85%, ideally closer to 90% of their age-predicted maximum heart rate, which is calculated as 220 minus their age. Reaching that target without problems is a good sign.
Okay. Now, the notes emphasize the importance of proper preparation before the test. What does the patient need to do?
Several things are important for safety and accuracy. They typically need to be NPO nothing by mouth, except maybe small sips of water with medications for about 4 hours beforehand. This reduces the risk of nausea or aspiration during exertion.
Avoid stimulants.
Yes, definitely avoid caffeine and tobacco for a set period before the test, as these can affect heart rate and EKG readings. And critically, the physician will usually instruct the patient to hold certain heart medications, particularly beta blockers, on the morning of the test.
Why hold beta blockers?
Because beta blockers slow the heart rate and blunt the response to exercise. We need to see how the heart performs without that medication effect to get an accurate assessment of their coronary reserve. An IV line is usually placed just in case medications are needed during the test.
Okay, so the patient is prepped. They start the test. What determines if the test is positive, meaning it indicates a problem? When do you stop?
A positive stress test means the test revealed evidence of ischemia. We would stop the test immediately if the patient develops significant chest pain, angina, becomes severely short of breath or excessively fatigued, experiences a drop in blood pressure or heart rate, which is abnormal during exercise, or most importantly, if the EKG shows diagnostic changes.
Like that ST depression we talked about.
Exactly. Significant ST segment depression is a classic sign of exercise-induced ischemia, or if they develop dangerous arrhythmias. Any of these findings constitute a positive test, indicating likely significant coronary artery disease that needs further investigation, often with cardiac catheterization.
And the goal is a negative test.
Right. A negative test means the patient reached their target heart rate without developing any symptoms or significant EKG changes, suggesting that blood flow is likely adequate, at least under those stress conditions.
So if someone does have angina, the goal of treatment, as the notes state, is pretty straightforward. Decrease the heart's oxygen demand and increase the oxygen supply.
That's the core principle. We need to rebalance that supply-demand equation.
And the cornerstone medication for immediate relief of angina is nitroglycerin, NTG. How does it work?
Nitroglycerin is a potent vasodilator. It relaxes smooth muscle in blood vessels throughout the body. This has a couple of key effects that help with angina. First, it dilates veins, which reduces the amount of blood returning to the heart that lowers preload.
Less stretch on the heart.
Right. Second, it dilates arteries, which reduces the resistance the heart pumps against that lowers afterload.
Less resistance to pump against.
Exactly. By reducing both preload and afterload, NTG significantly decreases the heart's workload and therefore its oxygen demand. Plus, it also helps to dilate the coronary arteries themselves, which can directly increase blood flow, the oxygen supply to the heart muscle, especially if there is some vasospasm involved.
Okay, so it tackles both sides of the equation. The notes are very specific about how to use it acutely, like for someone having chest pain at home. This is critical patient education.
Absolutely vital. For acute angina, the standard is sublingual NTG, a small tablet placed under the tongue where it dissolves quickly. The usual instruction is take one tablet immediately when pain starts. If the pain isn't gone in 5 minutes, take a second tablet. If it's still not gone after another 5 minutes, take a third.
And if the pain persists after 3 tablets over 15 minutes.
Call 911 immediately. Pain unrelieved by 3 doses of NTG is a major red flag for unstable angina or an evolving myocardial infarction. They need emergency medical services.
Any tips for administration?
The notes mention that for slightly faster absorption, the patient could gently crush the tablet between their teeth before placing it under the tongue, but just placing it under the tongue works well.
What about side effects and safety? What should patients expect or watch out for?
Because it's a vasodilator, the most common side effects are headache, often quite for lightheadedness due to a drop in blood pressure, hypotension.
So monitoring BP is important.
Crucial. Before giving NTG in a clinical setting, always check the BP. Patients at home should be taught to sit or lie down when taking it to avoid fainting if their pressure drops. They should report significant dizziness.
And how about storing it and using it long term?
NTG is very sensitive to light, heat, and air. It must be kept in its original dark glass bottle, tightly capped. The cotton packing should be removed once opened as it absorbs the drug. And the supply needs to be renewed regularly, usually every 6 months, because it loses potency quickly.
Can people use it preventatively?
Yes, absolutely. Patients should be taught to take a dose prophylactically before engaging in an activity they know usually brings on their angina.
And the huge warning, never take NTG with certain other drugs.
This is a life and death warning. Never, ever take NTG with medications used for erectile dysfunction like sildenafil, Viagra, tadalafil, Cialis, or vardenafil, Levitra. These drugs are also potent vasodilators, and the combination can cause a catastrophic, potentially fatal drop in blood pressure. Must be stressed repeatedly.
Okay, NTG for acute relief. What about drugs for chronic prevention of angina? Beta blockers come up frequently in the notes.
Beta blockers are a cornerstone of chronic, stable angina management. Drugs like metoprolol, atenolol, propranolol. They work by blocking the effects of adrenaline and noradrenaline on the heart's beta receptors.
So they counter that fight or flight response.
Exactly. This leads to a slower heart rate, lower blood pressure, and reduced force of contractility. All of these actions decrease the heart's workload and oxygen demand, making angina less likely to occur.
What are the main cautions or side effects to watch for with beta blockers?
You need to monitor for signs of too much effect: hypotension, low BP, bradycardia, slow heart rate, usually holding if pulse is below 50 or 60, or signs of heart failure exacerbation. Also, AV block can occur.
And the notes highlight 2 specific alerts, one for diabetic patients.
Yes, this is important. Beta blockers can mask some of the early warning symptoms of hypoglycemia, low blood sugar, like tremors and tachycardia, fast heart rate. Patients with diabetes need to be aware of this and rely more on monitoring their blood glucose and recognizing other symptoms like sweating or confusion.
And the other alert is about stopping the medication.
Critical point. Beta blockers should never be stopped abruptly, especially after long-term use. Suddenly withdrawing them can lead to rebound tachycardia, increased BP, and potentially worsen angina or even trigger an MI. They need to be tapered off gradually under medical supervision.
And there's a distinction between selective and non-selective beta blockers.
Yes. Non-selective beta blockers, like propranolol, block both beta-1 receptors, mostly in the heart, and beta-2 receptors, mostly in the lungs and blood vessels. Blocking beta-2 receptors can cause bronchoconstriction. Therefore, non-selective beta blockers are generally contraindicated or used with extreme caution in patients with asthma or COPD. Selective beta blockers like metoprolol or atenolol primarily target beta-1 receptors, making them safer for patients with respiratory issues, although caution is still needed.
Okay. Another class mentioned for angina are calcium channel blockers, CCBs. When are these typically used?
CCBs like diltiazem, verapamil, amlodipine work by blocking calcium from entering smooth muscle cells in blood vessels and the heart. This causes vasodilation, lowering afterload and increasing coronary blood flow, and decreases heart rate and contractility, lowering oxygen demand. They are particularly useful for angina caused by coronary artery vasospasm, Prinz-Metals angina, and can be used as an alternative or add-on to beta blockers for stable angina.
Any specific cautions with CCBs noted?
Some CCBs, particularly nifedipine, can interact significantly with grapefruit juice, leading to higher drug levels and increased side effects, so patients should be advised to avoid it. Certain CCBs, like verapamil, can sometimes worsen heart failure, so patients should report signs like worsening peripheral edema. And similar to beta blockers, we need to monitor heart rate and blood pressure, holding the drug typically if the heart rate drops below 50 or 60.
Okay, makes sense. Finally, the notes cover medications aimed at preventing the clot that can cause unstable angina, or MI, antiplatelets, and anticoagulants.
Right, these don't directly treat the ischemia, but they prevent the progression to infarction if a plaque ruptures. Antiplatelet drugs like aspirin, ASA, and clopidogrel, Plavix, work by making platelets less sticky, preventing them from clumping together to form a clot.
Aspirin is key in the acute setting.
Yes. For someone with new onset chest pain suggestive of ACS, the initial dose of aspirin is usually 162 to 325 milligrams, often chewed for faster absorption, followed by a lower daily maintenance dose. Clopidogrel is often added, especially after procedures like stenting, dual antiplatelet therapy, or DAPT.
And anticoagulants?
Anticoagulants like heparin, given 4V or subcutaneously, or low molecular weight heparins like enoxaparin, Levinox, given subcutaneously, work higher up in the clotting cascade to inhibit the formation of fibrin clots. These are often used acutely during ACS or around procedures like PCI.
What are the main nursing considerations when patients are on these potent anti-clotting drugs?
Bleeding risk is paramount. Monitor constantly for any signs of bleeding, obvious bleeding like nosebleeds or blood in urine stool, and also subtle signs like bruising, petechia, or changes in vital signs suggesting internal bleeding. Patients should use soft toothbrushes, electric razors, avoid unnecessary intramuscular injections as they can cause large hematomas.
And a specific complication with heparin.
Yes, watch out for heparin-induced thrombocytopenia, HIT, a dangerous immune reaction where platelet counts drop dramatically, paradoxically increasing the risk of thrombosis. Requires immediate cessation of heparin.
You mentioned Levinox, enoxaparin, earlier. Notes highlight a specific technique about the air bubble in the pre-filled syringe. Could you explain that again?
Right. Levinox syringes come pre-filled with a small nitrogen bubble. The instruction is do not expel the air bubble before giving the subcutaneous injection.
Why not?
That air bubble serves as an airlock. When you inject the medication, the bubble follows last, pushing the entire dose deep into the subcutaneous tissue and helping to seal the needle track as you withdraw. This minimizes leakage of the medication back out and reduces bruising and irritation at the injection site. So, leave the bubble in.
Good practical tip. Lastly, adjunct therapies mentioned are morphine and oxygen.
Yes, in the acute setting of severe angina or suspected MI, morphine is used primarily for pain relief, which is crucial, but it also has some beneficial side effects. It can cause mild vasodilation, reducing preload and afterload slightly, and very importantly, it reduces anxiety. Less anxiety means less catecholamine release, which lowers cardiac workload.
And oxygen.
Oxygen administration, usually via nasal cannula at 2 to 4 lm, is standard practice at the onset of chest pain, especially if oxygen saturation is low, 90% or uncertain. The goal is simply to maximize the oxygen supply available to the potentially ischemic heart muscle. We monitor to avoid potential oxygen toxicity with prolonged high-flow use, but acutely, ensuring adequate oxygenation is key.
Okay, we've covered angina, the warning sign. Now we move to the event itself. Myocardial infarction, or MI, a heart attack. This is where ischemia progresses to actual tissue death, right?
Exactly. MI is a form of acute coronary syndrome where blood flow through a coronary artery is completely blocked, usually by that thrombus forming on a ruptured plaque. This prolonged lack of oxygen leads to irreversible damage necrosis, or death of the heart muscle tissue supplied by that artery.
Necrosis, meaning that part of the heart muscle is gone for good.
Gone for good. It turns into scar tissue over time, which doesn't contract. This loss of functioning muscle is what can permanently impair the heart's pumping ability and lead to complications like heart failure or arrhythmias.
And the key clinical sign that really separates MI pain from even unstable angina pain, according to notes.
The defining characteristic of MI pain is that it's typically sudden, severe, and persistent. Crucially, it continues despite rest and administration of nitroglycerin. That lack of relief is a huge indicator that something more serious than transient ischemia is happening. Tissue is actively dying.
What about the other associated signs? Are they usually more intense with MI?
Often, yes. You'll frequently see profound shortness of breath, significant nausea and vomiting, overwhelming anxiety, and a sense of impending doom. And the physical appearance is often stark. The skin is typically cool, pale, and clammy or diaphoretic, sweaty, due to the body's massive stress response and potentially poor cardiac output causing reduced peripheral perfusion. Heart rate and respiratory rate are usually elevated as the body tries to compensate. Hashtag tag tag 4.2 diagnostics and biomarker timing.
When an MI is suspected, the mantra is time is muscle. Diagnostics need to happen lightning fast. What's the very first, most critical diagnostic step?
The 12-lead ECG. It absolutely must be obtained and interpreted within 10 minutes of the patient's arrival in the emergency department or their report of chest pain in the hospital.
10 minutes. That's incredibly fast.
It has to be, because the initial ECG findings often dictate the entire immediate treatment pathway, especially whether the patient needs emergency reperfusion.
Okay, so based on that initial ECG and subsequent blood tests,
Yeah.
biomarkers, the notes differentiate the types of acute coronary syndrome. Can you recap those for us?
Sure. There are basically three categories. One, unstable angina. The patient has symptoms suggestive of ACS. The ECG might show some ischemic changes like ST depression or T-wave inversion, but the cardiac biomarkers, blood tests for heart muscle damage, remain normal. This means there's significant ischemia, but no detectable myocardial necrosis yet. Two, STEMI, ST elevation myocardial infarction. This is diagnosed primarily by the ECG showing significant ST segment elevation, usually 1 millimeter, in 2 or more contiguous leads. This indicates acute, full-thickness injury is happening right now, and it requires immediate reperfusion therapy, PCI or thrombolytics. Biomarkers will eventually rise, confirming the MI3 and STEMI, non-ST elevation myocardial infarction. In this case, the patient has symptoms and the cardiac biomarkers are elevated, confirming myocardial necrosis has occurred. However, the ECG does not show the classic ST segment elevation. It might be normal or show ST depression or T-wave inversion. And STEMI still indicates a heart attack, requires hospitalization and treatment, but the immediate pathway might differ slightly from STEMI, often involves anticoagulation and potentially delayed invasive strategy.
So the biomarkers are key for confirming in STEMI and also for confirming STEMI after the initial ECG.
Exactly. They confirm that actual heart muscle damage has occurred.
Which biomarker is the most important one, according to them?
Troponin, specifically cardiac troponin T or troponin I. These proteins are released into the bloodstream only when heart muscle cells die, making them highly specific indicators of myocardial injury.
How quickly do troponin levels rise?
They typically start to rise within 3 to 6 hours after the onset of damage. This is why initial levels might be normal if the patient presents very early. We usually draw serial troponin levels, often 3 sets, maybe 6 hours apart, to look for a characteristic rise and fall pattern, which confirms the diagnosis.
And how long do they stay elevated?
That's another useful feature. Troponin can remain elevated for up to 2 weeks after an MI. This allows for diagnosis even if the patient presents days after the event.
What about the other enzymes mentioned, like CKMB and myoglobin? Are they still used?
They are, but they're less specific or have limitations. CKMB, creatine kinase myocardial band, is more specific to the heart than total CK, but less specific than troponin. It rises within a few hours, peaks around 24 hours, and returns to normal within 2-3 days. This shorter time frame can sometimes be useful for detecting reinfarction, a second heart attack soon after the first. Myoglobin is released from any damaged muscle, not just the heart. It rises very early, within 1-3 hours, but its lack of specificity makes it less useful for definitive diagnosis, though a negative myoglobin early on can sometimes help rule out MI quickly. Troponin remains the gold standard. Hashtag tag TAD 4.3, acute treatment and reperfusion strategy.
Okay, so we've diagnosed an MI. Time is muscle. What are the absolute immediate goals of treatment?
Minimize the extent of myocardial damage, preserve the function of the left ventricle as much as possible, and prevent complications like lethal arrhythmias or heart failure.
This starts with that initial bundle of care, right? The notes mention OANM.
Yes, that's a common acronym, though the order might vary. Oxygen if needed, aspirin chewed, nitroglycerin, sublingual or IV if BP allows, and morphine for pain. This initial package aims to relieve pain, reduce myocardial oxygen demand, and inhibit further clot formation.
And beta blockers usually follow soon after.
Yes, unless contraindicated, like in acute heart failure or severe bradycardia, oral beta blockers are typically started within the first 24 hours once the patient is stable. They help reduce heart rate, BP, and contractility, decreasing oxygen demand, and potentially limiting infarct size and reducing the risk of arrhythmias.
But the most critical intervention, especially for STEMI, is opening that blocked artery reperfusion. The notes strongly favor PCI,
Percutaneous coronary intervention, PCI, basically angioplasty, often with stenting, is the preferred method for reperfusion if it can be done quickly. It mechanically opens the artery. The benchmark goal is a door-to-balloon time of 60 minutes or less.
Door to balloon, meaning from the moment the patient hits the hospital door to the moment the balloon is inflated inside the blocked artery.
Exactly. That 60-minute window is critical. Studies show that the faster the artery is opened, the better the outcome, the more heart muscle is saved.
What if PCI isn't available quickly, maybe at a smaller hospital without a cath lab?
Then the alternative reperfusion strategy is thrombolytic therapy using clot-busting drugs like alteplase, TPA, or tenecteplase. These drugs work by dissolving the thrombus that's blocking the artery.
But these carry significant risks.
Yes, the major risk is bleeding, including potentially fatal intracranial hemorrhage, bleeding in the brain. Therefore, thrombolytics are used only for STEMI patients when PCI cannot be performed within the recommended time frame, usually within 90-120 minutes of first medical contact.
Is there a time window for thrombolytics too?
Yes, they are most effective when given early. The goal is a door-to-needle time of 30 minutes or less, and they are generally indicated only if administered within 6 hours of symptom onset. Some benefit up to 12 hours, but earlier is much better. There's also a long list of contraindications, primarily related to bleeding risk, like recent major surgery, trauma, history of hemorrhagic stroke, active internal bleeding, etc. Careful screening is essential.
Okay, so reperfusion is key. After the acute phase, the notes mention other medications started long-term, like ACE inhibitors. Why are those important post-MI?
ACE inhibitors like lisinopril, ramipril, or ARBs, angiotensin II receptor blockers like losartan, valsartan, play a crucial role in preventing adverse ventricular remodeling.
Remodeling, what's that?
After an MI, the heart tries to heal, but this process can sometimes lead to maladaptive changes. The damaged area becomes scar tissue, and the healthy parts of the ventricle may dilate and hypertrophy thicken to compensate. Over time, this remodeling can change the shape and size of the ventricle, making it less efficient and eventually leading to heart failure. ACE inhibitors and ARBs help to block hormones that drive this remodeling process, preserving ventricular function long term.
Got it. What are the key nursing points for ACE inhibitors again? We touched on them with HTN.
The main side effect to educate patients about is that persistent, dry, hacking cough. If it's intolerable, they'll likely be switched to an ARB. The most serious, though rare, adverse effect is angioedema, sudden swelling of the lips, tongue, throat, which is a medical emergency requiring immediate discontinuation and treatment. Also monitor BP and potassium levels.
Makes sense. And finally, post-MI care involves cardiac rehabilitation. The notes break this into phases.
Yes, cardiac rehab is a comprehensive, medically supervised program designed to help patients recover faster and reduce their risk of future heart problems. Phase 1 begins in the hospital. Focuses on gradual mobilization, sitting up, walking short distances, patient and family education about the heart condition, medications, diet, activity progression, and psychological support. Phase 2 starts shortly after discharge. Usually involves outpatient sessions 2-3 times a week for several weeks or months. Includes monitored exercise, often with ECG telemetry, ongoing education on risk factor management, smoking cessation, diet, stress, and counseling. Phase 3, a long-term maintenance phase. May involve transitioning to independent exercise at home or in a community setting, like a gym, with continued focus on maintaining lifestyle changes and risk factor control. It's about lifelong secondary prevention. Phase 3, hashtag tag 4.4 invasive procedures, PCI and CABG.
Let's spend a bit more time on those invasive procedures used to restore blood flow. We mentioned PCI as the go-to for acute MI. Can you elaborate on what PCI actually involves?
Sure. PCI is an umbrella term for procedures done via catheterization to open blocked coronary arteries. The most common type is PTCA, percutaneous transluminal coronary angioplasty, where a catheter with a small balloon on its tip is threaded up to the blockage. The balloon is inflated, compressing the plaque against the artery wall to widen the lumen.
And often a stent is placed.
Very often, yes. A stent is a small, expandable mesh tube, usually made of metal. It's mounted on the balloon catheter. After the balloon opens the artery, the stent is deployed, acting like a scaffold to hold the artery open and prevent it from re-narrowing restenosis. Many stents are now drug-eluting, meaning they're coated with medication that slowly releases to further inhibit scar tissue growth inside the stent.
Are there other types of PCI?
Yes, sometimes an atherectomy device might be used. This involves a catheter with a tool on the end, like a tiny drill or laser, to actually remove the plaque material from the artery wall rather than just compressing it.
Okay. Now, the nursing care after PCI is critical, especially concerning the access site where the catheter went in, usually the groin or the wrist.
Yes, femoral artery, groin, or radial artery wrist access are most common. Post-procedure care focuses heavily on preventing complications at that site, primarily bleeding or hematoma formation.
What specifically needs to be monitored?
Nurses need to frequently assess the access site for any signs of swelling, hardness, bruising, or active bleeding. Check the distal pulses in the affected limb, for example, pedal pulses of femoral access, radial ulnar if radial access, to ensure blood flow wasn't compromised. Monitor vital signs closely for hypotension or tachycardia, which could indicate bleeding.
And positioning is important.
Very important, especially with femoral access. The patient usually needs to lie flat or with the head of the bed only slightly elevated and keep the affected leg straight and immobile for several hours. Duration depends on the closure devices used, to allow the artery puncture site to seal and prevent bleeding. Pressure dressings or closure devices are used. Radial access allows for quicker ambulation.
Any other key post-PCI monitoring points from the notes?
Monitor for chest pain, as spasm or abrupt closure of the vessel can occur, though it's less common with stenting. Also, keep a close eye on kidney function, monitor urine output, BUN, and creatinine. The contrast dye used during the procedure can be nephrotoxic, especially in patients with pre-existing kidney disease or diabetes. Encouraging fluids, IV or oral, helps flush the dye out.
Okay, that covers PCI. Now, the other major intervention is coronary artery bypass graft surgery, or CABG. This is open heart surgery, right? Much bigger deal.
Much bigger deal. CABG is reserved for more extensive disease, typically significant left main coronary artery blockage or disease in 3 or more major coronary arteries, triple vessel disease, or sometimes if PCI isn't feasible or has failed.
And how does it work? They're literally bypassing the blockages.
Exactly. The surgeon takes a healthy blood vessel from another part of the body, commonly the saphenous vein from the leg, or the internal mammary artery from the chest wall, and grafts it onto the aorta and then onto the coronary artery beyond the point of blockage. This creates a new pathway for blood to flow to the heart muscle, bypassing the obstruction. Multiple bypasses can be done during one surgery.
Recovery from CABG is intense, ICU stay, high risks.
Definitely an ICU stay initially. The immediate post-op period involves managing multiple lines, chest tubes to drain fluid air from around the heart and lungs, mechanical ventilation initially, and close hemodynamic monitoring. Key risks include bleeding, arrhythmias, especially atrial fibrillation, which is very common post-CIBG, potential infection, sternal wound or graft site, and complications related to anesthesia and being on the heart-lung machine during surgery, though some CAG is done off-pump. Pain control is also a major focus.
The notes highlight some key nursing interventions for preventing post-op complications, particularly related to mobility and lungs.
Yes, early mobilization and pulmonary care are absolutely vital to prevent major problems like DVT, deep vein thrombosis, PE, pulmonary embolism, atelectasis, lung collapse, and pneumonia.
What is the goals?
Patients are typically expected to be out of bed to a chair on post-op day 1, POD1, and ambulating soon after, often starting POD1 as well. Aggressive pulmonary hygiene is key. Using an incentive spirometer every 1 to 2 hours while awake helps keep the lungs expanded and clear secretions. Coughing and deep breathing exercises, splinting the incision with a pillow for support are also critical. The notes also mention encouraging the patient to shower daily once cleared, which helps reduce skin bacteria and lower infection risk at the incision sites. Strict adherence to sternal precautions, no pushing, pulling, or lifting more than 5-10 pounds for 6 to 8 weeks, is crucial for healing the breastbone.
All right, let's shift gears to some of the major chronic cardiovascular conditions, starting with the one that underpins so much of what we've discussed, hypertension, HTN. The notes call it the silent killer.
And for good reason. Hypertension is simply defined as persistently elevated blood pressure. Remember, BP equals cardiac output x peripheral resistance. Because it often has no symptoms until complications arise, people can have it for years without knowing, while it's silently damaging blood vessels throughout the body, the heart, brain, kidneys, eyes.
It's a major driver of that endothelial injury we talked about earlier, right? Accelerates atherosclerosis.
Absolutely. The constant high pressure damages the artery lining, makes plaque build up more likely, and forces the left ventricle to work much harder to pump against that resistance, which can lead to thickening, hypertrophy, and eventually heart failure.
How is it diagnosed? Just one high reading isn't enough?
No, diagnosis requires an average of 2 or more properly measured high readings on 2 or more separate occasions, office visits. Proper measurement technique is key: correct cuff size, patient rested, feet flat on floor, arms supported at heart level.
Let's review the blood pressure categories mentioned in the notes again.
Sure, normal. Less than 120 is systolic A and D, less than 80 diastolic, 12 to 80. Elevated. 120, 129 systolic A and D, less than 80 diastolic. This is the warning zone. Stage 1 hypertension. 130, 139 systolic OR, 80, 89 diastolic. Stage 2 hypertension. 140 or higher systolic or 90 or higher diastolic.
These stages guide treatment decisions, starting with lifestyle changes and then adding medications. We covered the main drug classes earlier: diuretics, beta blockers, ACE/ARBs, CCBs. What are the absolute core patient education points for managing HTN?
Lifestyle is foundational. Adopting the DISH dietary approaches to stop hypertension, or Mediterranean diet, significantly reducing sodium intake, maintaining a healthy weight, regular exercise, limiting alcohol, and smoking cessation. Medication adherence is critical. Patients need to understand they often need lifelong therapy and shouldn't stop meds just because they feel fine or their BP comes down.
And the warning about stopping meds abruptly applies here too.
Yes, especially with certain classes like beta blockers or clonidine. Abrupt cessation can cause dangerous rebound hypertension. Also, educate about potential side effects of their specific medications and when to report them. For diuretics, things like taking them in the morning, monitoring for dizziness or electrolyte imbalances, especially potassium.
Now, the notes draw a very important distinction between hypertensive urgency and hypertensive emergency. This impacts immediate management significantly.
Critically important distinction. Both involve very high blood pressure readings, but the difference lies in the presence or absence of acute target organ damage.
Okay, so what defines a hypertensive emergency?
A hypertensive emergency is severely elevated BP, often cited as 180, 120, or even 200, 140, though the absolute number is less important than the context. PLUS evidence of new or worsening damage to vital organs. This could be signs of stroke, neurological deficits, acute MI, chest pain, EKG changes, acute heart failure, pulmonary edema, aortic dissection, tearing chest back pain, acute kidney injury, or severe retinopathy.
And this requires immediate aggressive treatment.
Yes. Immediate admission to an ICU and treatment with intravenous IV antihypertensive medications like sodium nitroprusside, nicardipine, or labetalol. The goal is to lower the BP relatively quickly, but in a controlled manner, typically reducing the mean arterial pressure, MAP, by no more than 25% within the first hour, then gradually towards a target like 160-100 over the next 2-6 hours. Lowering it too fast can cause hyperperfusion and ischemia to the brain or heart.
Okay, so emergency organ damage, AV meds, and ICU. What about hypertensive urgency?
Hypertensive urgency is also severely elevated BP, EKG 100-120, but without any signs or symptoms of acute target organ damage. The patient might have a headache or feel anxious, but there's no evidence of stroke, MI, etc.
How's urgency treated differently?
It's still serious and needs treatment, but it's less immediately life-threatening. Management usually involves oral antihypertensive medications and close monitoring, often in an emergency department or urgent care setting, but typically not requiring ICU admission. The goal is to lower the BP more gradually over 24 to 48 hours. Rapid reduction isn't necessary and could be harmful. Hashtag 5.2 abdominal aortic aneurysm, AAA.
Next chronic condition noted is abdominal aortic aneurysm, or AAA. This is a weakening and bulging of the main artery in the abdomen, the aorta.
Exactly. It's a localized dilation or bulge in the wall of the aorta, specifically the part running through the abdomen, usually below the level of the renal arteries to the kidneys. The weakening primarily affects the medial layer, the middle muscular layer of the artery wall.
What are the major risk factors for developing in AAA? The notes list several.
Age is a big one. Risk increases significantly after age 65. It's much more common in men than women. Smoking is a huge risk factor, probably the most significant modifiable one. Genetics plays a role, family history. It's also noted to be more prevalent in Caucasians. And uncontrolled hypertension contributes by putting constant stress on the aortic wall. Atherosclerosis itself is also closely linked.
Like hypertension, AAAs are often asymptomatic, right? Found incidentally.
Very often, yes. They might be discovered on an ultrasound or CT scan done for some other reason. When symptoms do occur, they can be vague. Some people might feel a pulsating sensation in their abdomen, almost like feeling their heartbeat there. Or they might have persistent deep abdominal or back pain, sometimes described as gnawing.
Can it be detected on physical exam?
Sometimes, if the patient isn't too obese, a clinician might be able to palpate a pulsatile abdominal mass above the umbilicus. Listening with a stethoscope over the area might reveal a bruit, a whooshing sound caused by turbulent blood flow through the aneurysm.
How is management decided? The notes mention size is the key factor.
Size is everything. The risk of rupture increases dramatically as the aneurysm gets bigger. So for small AAAs, less than 5.5 centimeters in diameter, the approach is typically watchful waiting,
Meaning?
meaning regular surveillance with ultrasound or CT scans, usually every 6 to 12 months, to monitor for any growth. And crucially, aggressive risk factor modification. This includes absolute smoking cessation and strict blood pressure control. The goal is often to keep BP on the lower side, maybe systolic 100, 120, to reduce stress on the aneurysm wall.
And if the aneurysm reaches that critical size threshold or becomes symptomatic?
Once an AAA reaches 5.5 centimeters or larger, or if it's growing rapidly, or if the patient develops symptoms related to it, like pain, then surgical intervention is usually recommended because the rupture risk outweighs the surgical risk.
What are the surgical options?
There are two main approaches. One, open surgical repair. This involves a large abdominal incision, clamping the aorta above and below the aneurysm, cutting out the aneurysmal section, and sewing in a synthetic graft tube to replace it. It's a major operation with significant recovery time. Two, endovascular aneurysm repair, EVAR. This is a less invasive procedure done via catheters inserted through small incisions in the groin. A collapsed stent graft, a fabric tube supported by a metal mesh, is guided up into the aorta and positioned inside the aneurysm. It's then expanded, effectively lining the aneurysm and excluding it from blood flow and pressure. EV has a faster recovery but requires lifelong surveillance imaging to check for leaks or graft migration.
Okay, and the worst case scenario is rupture. What are the signs of an acute AAA rupture? This is a dire emergency.
Catastrophic. Signs include the sudden onset of severe tearing abdominal or back pain, often radiating to the flank or groin. Patients rapidly develop signs of hypovolemic shock due to massive internal bleeding, profound hypotension, tachycardia, pale clammy skin, altered mental status. You might see bruising on the flanks, gray Turner sign, or around the umbilicus, Cullen sign, from the retroperitoneal hemorrhage, though these are later signs. Rupture has a very high mortality rate, even with immediate surgery. Hashtag 5.3 heart failure, HF.
Finally, we arrive at heart failure, HF. The notes position this as often the end stage of many other cardiovascular diseases like long-standing HTN or damage from MI. What's the fundamental problem in HF?
At its core, heart failure means the heart muscle is unable to pump blood effectively enough to meet the body's metabolic demands for oxygen and nutrients. Or sometimes it can only do so if the filling pressures inside the heart become abnormally high. It's not that the heart has stopped, but that it's failing as an efficient pump.
The notes make a clear distinction based on which side of the heart is primarily failing. Left-sided versus right-sided failure. Let's start with left-sided. Where do the symptoms manifest?
Think L for left, L for lungs. If the left ventricle, the main pumping chamber sending blood out to the body, is weak or stiff, it can't effectively pump blood forward. This causes blood to back up behind it into the left atrium and then into the pulmonary veins and capillaries in the lung.
Leading to pulmonary congestion.
Exactly. Fluid leaks into the lung tissues and air spaces. This causes the classic symptoms of left-sided HF dyspnea, shortness of breath, especially with exertion, DOE, orthopnea, difficulty breathing when lying flat, needing to prop up on pillows to sleep, paroxysmal nocturnal dyspnea, PND, suddenly waking up at night gasping for air, cough, often persistent, sometimes productive of frothy or pink-tinged sputum indicating pulmonary edema, crackles, rales, heard on lung auscultation indicating fluid in the alveoli, S3 heart sound, an extra heart sound, ventricular gallop, often heard.
This is often called systolic heart failure, or HFrEF, HF with reduced ejection fraction.
Often, yes. Left-sided failure is commonly associated with a weakened pump, a reduced ejection fraction.
Okay, so if the left side fails, pressure builds up backward. What happens with right-sided failure? Where does the fluid back up then?
Think R for right, R for rest of body. Right-sided failure usually occurs because the right ventricle is struggling to pump blood forward into the lungs, often because pressure is high there due to left-sided failure or lung disease. So blood backs up behind the right ventricle into the right atrium and then into the systemic venous circulation.
So symptoms appear in the body.
Right. Signs of systemic venous congestion include jugular venous distension, JVD, bulging neck veins, peripheral edema, swelling, typically in the feet, ankles, and legs, dependent edema, ascites, fluid accumulation in the abdominal cavity, hepatomegaly, enlargement of the liver due to congestion may cause tenderness in the right upper quadrant. Weight gain, this is a key sign, resulting from the fluid retention.
People can have both, right?
But
Biventricular failure.
very commonly, yes. Often left-sided failure leads to right-sided failure over time.
How is HF diagnosed? The notes highlight a key blood test and an imaging test.
Two major diagnostic tools are: 1. BNP, B-type natriuretic peptide. This is a hormone released by the heart's ventricles primarily in response to being stretched by high volume or pressure. In heart failure, BNP levels become significantly elevated. Higher levels generally correlate with more severe HF. It's very useful for differentiating shortness of breath caused by HF from that caused by lung disease, and also for tracking response to treatment. 2. Echocardiogram, echo. This is an ultrasound of the heart. It's crucial for assessing the heart's structure and function, chamber sizes, wall thickness, valve function, and importantly, it measures the ejection fraction, EF.
EF, that's the percentage of blood pumped out of the left ventricle with each beat. What's normal?
Yes. Normal EF is typically around 55% to 65%, and EF below 40% indicates systolic dysfunction, HFrEF.
But the notes mention that EF can sometimes be normal in heart failure. Diastolic HF.
This is a really important point. Yes, a significant number of HF patients have HFpEF heart failure with preserved ejection fraction. This used to be called diastolic heart failure. In HFpEF, the EF measurement might be normal or near normal, 50%. The problem isn't necessarily that the ventricle can't squeeze effectively, systolic function, but rather that the ventricle muscle is stiff or thickened, so it doesn't relax properly during diastole.
So it can't fill adequately.
Exactly. The ventricle can't fill with enough blood, so even though it ejects a normal percentage of what's there, the total amount of blood pumped out, stroke volume, is still reduced, leading to HF symptoms. HFpEF is common, especially in older adults, women, and those with hypertension or diabetes.
Okay, that's a key nuance. Let's talk treatment. Non-pharmacologic measures focus on managing fluid volume.
Absolutely. Key strategies include positioning. Elevating the head of the bed, semi-Fowler's or high Fowler's position, can ease breathing by reducing venous return and pressure on the diaphragm. Fluid restriction. Limiting daily fluid intake is often necessary to prevent volume overload. Sodium restriction. A low-sodium diet, typically 2 grams a day, is crucial to help prevent fluid retention. Daily weights. This is probably the single best indicator of fluid status changes. Patients must weigh themselves every morning after avoiding, before breakfast, wearing similar clothing and using the same scale. They need to report any sudden weight gain like 2-3 pounds in a day or 5 pounds in a week, as this usually signifies worsening fluid retention requiring intervention.
Okay, daily weights are key. Now, pharmacologic therapy. We've mentioned ACE inhibitors, ARBs, and beta blockers are mainstays for HFrEF. Diuretics are obviously used for fluid removal, but the notes dedicate specific attention to an older drug, digitalis or digoxin.
Yes, digoxin has been used for centuries, though its role has evolved. It has 2 main effects. It's a positive innertrope, meaning it increases the force or strength of the heart's contraction, which can improve cardiac output, and it's a negative chronotrope, meaning it slows down the heart rate, particularly conduction through the AV node, which can be helpful in patients with HF and concurrent AFib.
But it has a notorious reputation for toxicity. Narrow therapeutic range.
Very narrow therapeutic range, meaning the difference between an effective dose and a toxic dose is small. This requires careful dosing and monitoring.
What is the absolute essential nursing safety check before giving digoxin?
Before administering any dose of digoxin, the nurse must assess the patient's apical pulse, listening directly over the heart with a stethoscope for 1 full minute.
Why apical? Why 1 full minute?
Apical pulse is most accurate. A full minute is needed to detect any irregularities in rhythm and to get an accurate rate, especially since digoxin slows the heart. The critical rule is hold the dose and notify the physician if the apical pulse is less than 60 beats per minute in an adult, or per specific order parameters. Giving digoxin to someone already bradycardic could be dangerous.
Okay, hold a pulse 60. The notes also mention a crucial interaction with potassium levels.
Yes, this is vital. Hypokalemia, low serum potassium, significantly increases the risk of digoxin toxicity. Potassium and digoxin compete for the same binding sites on the NAD plus K plus ATPase pump in heart cells. If potassium is low, digoxin binds more readily, leading to excessive effect and toxicity even at normally therapeutic drug levels. So monitor potassium levels closely, especially if the patient is also on potassium-wasting diuretics like Lasix.
And if digoxin toxicity does occur, what are the signs and symptoms nurses and patients need to watch for?
Early signs are often nonspecific and gastrointestinal: anorexia, loss of appetite, nausea, vomiting. Patients may also experience fatigue or muscle weakness. Cardiac signs include bradycardia, new heart block, or other arrhythmias. But the most classic, almost pathognomonic signs mentioned in the notes relate to vision. Patients may report visual disturbances such as blurred vision, seeing yellow or green spots, or seeing halos around lights.
Yellow-green halos, that's the textbook sign.
That's the one always emphasized. Any of these symptoms, especially the visual changes or significant GI upset, warrant holding the drug, notifying the physician, and checking a digoxin level on electrolytes immediately. There's an antidote. Digoxin Immune Fab, Digibind, available for severe toxicity. #tag outro.
Wow. Okay, that was indeed a deep dive.
Right.
We went from the absolute basics, cardiac output, preload, afterload, right through the nitty-gritty of EKG interpretation. The whole pathway of atherosclerosis, managing angina, the critical steps during an MI, invasive procedures like PCI and CABG, and finally tackling chronic conditions like hypertension, AAA, and the complexities of heart failure, including that tricky digoxin. We really tried to pull out all the detail from these comprehensive notes.
We definitely covered a lot of ground, but hopefully structuring it this way helps connect the dots. You can really see the narrative unfold, can't you? How those initial risk factors like smoking or high blood pressure lead to that endothelial injury.
Which starts the atherosclerosis.
Right, which then manifests as angina when demand outstrips supply.
And can culminate in the acute crisis of MI if a plaque ruptures.
Or eventually lead to the chronic pump dysfunction of heart failure. It's all interconnected.
And hopefully highlighting those crucial time frames, the 10-minute EKG, the 60-minute door to balloon, and those specific nursing actions, like checking the apical pulse for digoxin or remembering not to expel the Levinox bubble, gives you, the listener, a really solid framework for understanding and managing these conditions based on this source material.
Exactly. It's about applying that knowledge effectively. And maybe for a final thought to leave listeners with, we spend so much time detailing the consequences, the diseases, the interventions needed after the damage is done. But what if we circle all the way back to the beginning? Back to those modifiable risk factors, that metabolic syndrome cluster we talked about, the waistline, the lipids, the BP, the glucose. We described this whole cascade today, starting with endothelial injury.
So the provocative thought is, what if we stop it there?
What if, through consistent, long-term adherence to those preventative measures, keeping BP truly controlled, managing lipids and glucose aggressively, not smoking, maintaining a healthy weight and diet, what if we could fundamentally prevent that initial injury?
Then the whole cascade we just spent time detailing might never even start for that person.
Precisely. Understanding the pathophysiology, the downstream effects we discussed today, really underscores the immense power of prevention. It's not just about treating disease, it's about stopping the story before the tragic chapters are written. That's the real potential impact of applying this knowledge proactively.
Excellent point. Definitely food for thought. Thank you for joining us for this deep dive. We'll catch you next time.